Okay, good morning, everyone. I think everyone's just joining. So today it is my pleasure to welcome Dr. Nathalie Agar as our Grand Rounds visiting professor today. Dr. Agar comes to us from the Brigham, where she is the Daniel E. Ponton Distinguished Chair in Neurosurgery and Associate Professor of Neurosurgery and Radiology at Harvard Medical School. Dr. Agar completed her BS in biochemistry in Quebec, after which she received a PhD in chemistry at Concordia University in Montreal. She then completed a postdoctoral fellowship in neurosurgery at McGill University. She finally made her way to Boston, where she then completed a second postdoctoral fellowship in neurosurgery at Harvard Medical School, and she then completed a program in executive leadership at Harvard Business School. This unique training and this mix of neurosurgery and science really positioned her ideally to launch a truly stellar career in translational research, and she has bridged the gaps between science, medicine, and surgery. She currently runs a research laboratory at Brigham and Harvard Medical School and the Dana-Farber Cancer Institute, where she aims to develop mass spectrometry and optical imaging approaches for surgical pathology and oncology. She received the NIH Director's New Innovator Award in 2010 for her work developing real-time mass spectrometry tissue analysis to guide intraoperative cases for neurosurgery. She also has really driven tremendous innovation in imaging, particularly looking at drug imaging, pairing radiology with pharmacodynamic analysis. And her work is very compelling, and we are thrilled to hear more about it. So Dr. Agar, welcome, and thank you for joining us today.
Thank you so much, Rupa, and good morning, everybody. I so much wish I could have come over and visit all of you. It is a little awkward to talk to my computer like this, but thankfully I see Rupa. So today I'll talk to you about some of the applications that we've been developing to apply mass spectrometry imaging for neurosurgery and also for neuro-oncology. Oh, and okay, here are my disclosures. Can you see my cursor, Rupa?
Yes, I can.
Okay, because the control is strange. So in brief, the applications that we've been developing for surgical pathology and oncology rely on, the first line of application is to identify surgical margins. So is it tumor versus non-tumor during surgery? The second line of application is to be able to provide diagnostic and prognostic information such as tumor type, grade, behavior such as recurrence and progression. And eventually what we would like to be able to do is to predict response to targeted therapy. And the other line of work that we had been developing, which I used to think was very separate from all of this, was to assess drug distribution and response for brain tumors. And we started off in preclinical animal models with a focus on brain penetrance. And we've since made those applications quantitative and have been applying them to clinical trial. And hopefully I'll be able to show you how all of this work actually ties in very well with the more clinical applications for surgical care. So the core of our work happens in the AMIGO, which is the Advanced Multimodality Image Guided Operating Suite at the Brigham. The AMIGO, if you're not familiar with it, it's a 3-room operating room. On one end, we have a 3 Tesla ceiling mounted MRI that can move to the patient here. We can bring the patient to a PET CT scanner. We have a full array of different imaging applications, but even with all of these tools, we still did not have a tool that would be able to assess tissue characteristics during surgery. So this is when we brought in the mass spectrometer to be able to do that, to provide molecular information during surgery. But one thing I like to say is that probably the most significant thing we did is we brought the neuropathologist into the operating room to do those analyses. The chemist and computational scientists here together with neurosurgeon, and a lot of this work is done in close collaboration, and I would say friendship at this point, with Dr. Alex Golby at the Brigham. So the workflow that we've developed to validate those analyses is to do stereotactic mass spectrometry. So we use, and I I don't have to teach you what neuronavigation is, but essentially we use neuronavigation to register every sampling location to preoperative or intraoperative MRI. And every position that we take a specimen, we do a mass spectrometry analysis, and we keep some of the tissue to do histopathology evaluation after, after surgery. So the line of work, we've done a lot of this work using machine learning, looking at molecular signatures of different types of tumor and grade and all, but where our most mature protocol so far is the one where we focus on a very specific metabolite to guide brain tumor surgery. So we have the first IRB approved protocol to be able to use this information in real time. And you're most likely all familiar with the IDH mutated tumor. And for a chemist, when we have an IDH mutation, is rather than to have the alpha ketoglutarate, we see an accumulation of the 2-hydroxyglutarate, which is different in mass from the native metabolite. So this is actually what we can follow during surgery. And here we can see part of a spectrum from a patient that has a wild type enzyme. And here we compare to a patient who has a mutated enzyme, and we can see this peak that comes up here at 147, but it is not, the type of instrumentation we use in the operating room is not enough to confirm that this is the metabolite of interest. So to further, to bring in the specificity, what we do is fragmentation of the metabolite into the mass spectrometer, and then the fragmentation pattern confirms that this is indeed the metabolite that we're looking at against other molecules that could be overlapping. And this might sound very long, but it just happens within the mass spectrometer on the second time scale. So to validate this approach, what we did is we took a collection of about 50 glioma specimens that had been tested for IDH mutation. So all of the specimens that were diagnosed with the IDH mutation based on the antibody immunohistochemistry stain, we were able to detect the metabolite here into the tissue. There were 3 specimens here that we detected metabolite, but we had been told were negative. So the pathologist revisited this tissue here and was able to find a block that had the mutation. And those 2 specimens here actually remained negative on immunohistochemistry. I don't know if I hear some background or my. Sorry.
Hi, anyone. If you're not muted, please mute yourself.
But when we did, what we did is we did sequencing of those 2 specimens, and in fact, we were able to detect a mutation in the IDH1, but it was a different mutation, arginine to glycine, which could not be picked up by the antibody. So even if we were to stop here and simply use this for diagnosis, we can easily detect different IDH mutation without the requirement of different antibodies directly by the detection of the 2-hydroxyglutarate. But one thing that I should say is that we can get this information within seconds as soon as we have access to the tissue specimen. So at the beginning of the case, as soon as the surgeon reaches the core of the tumor, we're able to confirm whether the patient has a mutation or not, which in some cases can change the surgical strategy. But the way that we use this for surgical margins is that we map the intensity of the metabolite in different locations here, and we've confirmed excuse me, the correlation of the intensity of the metabolite with the tumor cell concentration. So higher levels of the metabolite correlate very well with tumor cell concentration. But until here, all we can do is to say, well, there's more metabolite in this specimen than the next one. It was very qualitative. So what we've done now is to make this analysis quantitative. So to do this, we make what is called a tissue mimetic, which we use a lot for drug studies. We have a gelatin mold here that we've prepared tissue homogeneous extract that we spiked with known concentration of the metabolite. And prior to a case, we take a cross section of this that we mount on a glass slide. And then we can build a standard curve and determine the concentration of the specimens that we analyze. And we also introduce an isotopically labeled version of the metabolite to increase the specificity of the analysis. So what we are increasingly working to do is to actually bring this type of molecular information back into the MRI so that we can have perhaps a better understanding or validate some MRI sequences that we commonly use. So here you can see the intensity of the 2-hydroxyglutarate as it's mapped on the contrast enhancement and against the flare. So this is 2-hydroxyglutarate, but I'll show you that we can do similar work with an increasing number of metabolites. So the premise of our work had been initially to convert existing surgical devices to become sampling devices. We had originally thought we would work from the CUSA here and interface with navigation and to send basically the specimen directly into the mass spectrometer. The first line of work that we've been doing, which I just told you about, is one where we use an ambient ionization method. So the advantage is we don't need any sample preparation. We just place every little piece of tissue here on a slide and do the direct analysis. But we've recently partnered with a startup company in engineering where they've developed this ion tube where essentially we can produce, to be able to analyze molecules in mass spectrometry, we need to form ions, and this is what we're measuring. So we can form the ions directly at the site, so that would be within the surgical cavity, and then the ions can be transferred directly to the mass spectrometer, and we're working with different desorption ionization source here, but this is very early engineering work. So the other type of mass spectrometry application that we've been developing to support surgical decision making is one where we can do a very rapid analysis of molecular frozen section, which we want to say would provide you with a molecular frozen section. And so in this case, we use MALDI mass spectrometry imaging, so matrix-assisted laser desorption ionization. In this case, we take a frozen tissue section, and then we apply a matrix, which is a small organic acid that will serve to transfer the energy from an irradiant laser to molecules in the tissue so they can come off the surface for analysis. And we move the laser in an XY fashion over the tissue. In every position of analysis, we acquire a mass spectrum of a mass range of interest. Then we can mine the data and visualize different molecules of interest, for example, protein green, purple, or yellow here. And but one of the limitations in using this type of application is that traditionally it's been limited to an hour or an hour and a half workflow to produce one image. So the workflow is such that we use, well, we take a frozen tissue section, mount it on a glass slide. As I said, we apply the matrix. Then we have to set up the acquisition with the instrument with registration of the specimen to the instrument. And then we do the acquisition of the data here with a 1 kilohertz laser. So now we've recently published a study where we brought this type of analysis to less than 5 minutes. And the way that we have done that is that we pre-coat a glass slide with the matrix, delineate a region where the sample will be positioned, and the instrument now has a 10 kilohertz laser that was developed by the company, not by our group. So that now we can, from the time that we access the tissue, to be able to provide a detailed molecular analysis of a tissue section like this can be done under 5 minutes. So now if I switch gear and go to the studies that we're doing on drug distribution and response, we actually use similar technology, the MALDI mass spectrometry imaging. So I'm sure you're all aware we have quite large number of drugs that are highly efficacious against brain tumors, but that is if we put the brain tumor in the flank of an animal. The problem comes when we grow those tumors into the brain where they should be. This is where we typically lose the efficacy of those targeted therapies. And I will not teach you about the blood-brain barrier, but our group and other groups we work with have been focused on assessing the limitation imposed by the blood-brain barrier in treating the tumors. And so one experiment that we did to confirm this is essentially here we grew, those are all done, those are PDX models where we treated with this compound here. There is actually a little bit of drug, but for some reason right now on my screen, I don't see any, but it's a very low level, and we get very poor survival. Now what we did is we overexpress VEGF in those same tumor cells here, and what we saw is an increase in drug distribution into the tumor with an increase in efficacy. And we're definitely not saying that we should treat those tumors with VEGF, but it was mostly to see if an increase in drug uptake would correlate with an increase in response. Another fact or point that I would like to make here is that we also typically would think of, well, the blood-brain barrier is really disrupted in those tumors, and we picked this up on contrast enhancement. This is what we use for diagnosis. And we would typically think that drugs will distribute the same way as contrast would distribute in tissue. But here's an example of a tumor on H&E, and you can see the vascularization. Here we use heme, which is a cofactor of hemoglobin, as a marker of the vasculature. And we can see the distribution of the drug here in green, and we can see the distribution of Gadavis in the tissue, which is very different than the drug here. And that is even considering the fact that those two molecules were almost the same molecular weight. But as you can see here, they have very different chemistry. And so the physical chemical properties of compounds will definitely further affect their distribution. So even though we might be able to go across the blood-brain barrier, there are still limitations that are imposed into being able to distribute drugs into tissue or any molecules in a homogeneous way. So what we've wanted to do is to develop predictive MRI based model that would be non-invasive of where drugs might distribute and what kind of response that would elicit. So we've come together with Mayo Clinic and MIT, where we have a center on physical science oncology center. And essentially the workflow here is to be able to correlate MRI features with different sequences with what is happening into the tissue. So essentially we grow PDX tumors, and we perform MRI, and prior to sacrificing, then after sacrificing, we take multiple tissue sections throughout the 3D volume of the tumor, and then we do different types of analyses to be able to correlate drug levels with metabolism. We can do these in a quantitative fashion. We use stimulated Raman scattering imaging to be able to extract more structural features from the tissue without any labeling. We use phosphoproteomics to assess response. Combine this with laser capture microdissection and RNA-seq again to assess response. And recently we started applying cyclic immunofluorescence to validate those response markers here that we assess in bulk tissue. So when we want to assess a 3D volume, this is the type of workflow that we have to do. We take multiple sections throughout the 3D volume of the tumor. We can visualize drug distribution here in green with the vasculature. We can simultaneously image drug metabolites because we're following the mass of a molecule, so we're not dependent on molecular probes attached to the parent drug. So now to be able to visualize this, we can reconstruct the data in 3 dimensions and visualize the vasculature. We can visualize different markers of tumor versus normal. And here you can see the distribution of the drug erlotinib, which is a compound that we use a lot to develop the technology in EGFR inhibitor. And we can see the distribution of its pharmacologically active metabolite here. And what you will be able to see is that there's quite a significant difference in the distribution pattern of the drug and the pharmacologically active metabolite. There's definitely much more of the parent drug than the metabolite, but their distributions are different. And this is despite the fact that they only differ by a methyl group. So this is the type of information now that we can bring into our models to be able to assess drug distribution as they relate to their physical chemical properties, and hopefully being able to develop MRI-based model that we could use to predict drug distribution. So in order to do that, we need to perform a registration. One of the challenge is the mass spectrometry imaging data is extremely complex. It provides essentially one image is essentially thousands of images, which produces a data cube. And none of those images is enough information to be able to correlate to an anatomical image such as the MRI. So we do a dimensionality reduction of the mass spec data here to be able to extract anatomical features, which we then use to do a nonlinear registration to the 3D MRI. And once we have that, then we can visualize any molecules of interest that is within our mass spectrometry data cube within the MRI space. So here we can see the distribution of erlotinib, the drug that we imaged by mass spec within the MRI. And this is the type of information that we use now to feed into the predictive models. And we can do this here with T1 with contrast enhancement, but we do this with different MR sequences to see which ones or which combinations might be providing more predictive information. So each spectrum of an image is actually fairly complex, which is why we get about thousands of images per experiment. So here, this is one spectrum from an image, and we can see here the drug is this tiny peak here that is almost in the noise. Then we have our blood signal, but all of this here is information that we've been wanting to tap into to see if we could correlate with markers of response. So when we did the segmentation analysis of one of those PDX model here, we were able to see different patterns of distribution, different molecular signatures. And you can see here the core of the tumor and the edge of the tumor here. And now using a high resolving power instrument, we were able to identify the main molecules that were giving rise to that pattern at the edge of the tumor, and found a collection of acyl carnitines, which are molecules that are required to bring fatty acids to the mitochondria for the cells to switch their metabolism to beta oxidation. So now when we visualize this in 3 dimensions, again, we can see that it was not just one rim around one cross section, but in fact throughout the 3D volume of the tumor, which essentially appears to form like an envelope around the tumor that had a different form of metabolism than the core. And if we map the drug distribution into that space here, we can see that we have high levels of erlotinib in the core of the tumor, and then lower level in the normal part of the brain, but you can see a dark rim here that has absolutely no drug level. And if we map those two on top of each other, then we do see that the drug seems to be excluded from that region around the tumor. And what we're thinking is happening is this change in metabolism might give rise to a change in pH, could be one of the changes that affects distribution of the drug in this region. And we've confirmed that there's different forms of metabolism at the core of those tumors versus the edge. And we did this in a number of PDX model here. And we're able to see, you can see ATP here in the core of the tumor and some of the acylcarnitines at the edge. But we've also confirmed by RNA sequencing that the core of the tumor in those cases was more glycolytic, while the edge of the tumor or the envelope around the tumor is switching to a beta oxidation. So again, even if we are able to go across the blood-brain barrier in some cases, there might be other features in the tissue that prevent homogeneous distribution. So now bringing those studies together from animal models to clinical trial, we had been doing a few studies looking at the WEE1 inhibitor AZD1775 and to basically warrant a clinical trial based on drug uptake into the tumor and drug response. So for this study here, what we do is a combination of analysis between the analysis of clinical trial specimen and PDX models here. And each tissue that we analyze, we do standard histopathology evaluation. We use a high resolving instrument for mass spectrometry imaging to look at drug distribution and other metabolites. We use phosphoproteomics to look at protein signaling to assess response. And as I mentioned earlier, now we started including cyclic immunofluorescence to be able to visualize those markers of response here onto the tissue as it relates to drug uptake. So here, one thing we noticed in the animal models is that we had 3 different animal models here. Those are GBMs that are grown in the flank. So we would expect the drug uptake to be somewhat homogeneous. But what we saw is significant heterogeneity in drug response. So we went through the trouble of imaging the flanks from those animals and saw significant differences in drug uptake between the different models, but even between animals within a given model. Even though I have to say that the permeability of those models seems to be somewhat reproducible. There's still variability within a model, but a model that is more permeable will typically remain more permeable than one that is not even in the flank of the animal and of course in the brain. Another feature that we noticed here is that this specimen here was delineated to mark the regions of necrosis here, delineated in yellow, and the drugs seem to be excluded from those regions, again indicating that there might be tissue characteristics that prevent the distribution of different drug. And in fact, this drug we tested in that previous model that I showed you, where you have a change in metabolism, but that change in metabolism was not affecting the distribution of AZD1775, but it was affecting the distribution of erlotinib. So what we did here is to try to build models to correlate drug distribution and response, but working with truly drug exposure and not just dosage. And when we did this, it corrected for our models where we had very heterogeneous response. And in fact, we can get a correlation coefficient of over 0.8 here, so we can use the response to in fact predict the drug level into the tissue. Hopefully that made sense. So essentially, we see a very strong dose-dependent response, and it is so strong that we can predict drug levels based on the response itself. And here in the phosphoproteomics, we detected, we identified some markers of response that are basically DNA damage response. And we then took antibodies to be able to visualize those markers of response here and did cyclic immunofluorescence and combined with antibodies to assess proliferation in the cell cycle. And we were able to detect different clusters of non-cycling stroma cells, but also a cluster of high DNA damaged tumor cells. And when we visualize this over the histopathology, we can see, well, that is one way to validate that complex data analysis here, is that this is a dot representation, a dot plot, if you want, of the signal from each of those pixels. And we can see here the clusters of tumors based on the analysis of those multiple markers against the cycling stroma and the non-cycling stroma. What we saw here also is a strong increase in high DNA damage tumor cells in response to the drug. And then we transposed this to the analysis of clinical trial specimens, where in this clinical trial, specimens were collected in the contrast enhancing versus and the non-enhancing regions for most of the patients here. We performed analyses of drug imaging as it relates to the vasculature, and we're able to quantitate the drug here. And now what we can do qualitatively is to overlay all of those images, where we can look at the H&E with different markers from the cyclic immunofluorescence, but registered to the mass spectrometry imaging of the drug here, so that we have a correlation into the tissue at the pixel level of drug response to drug concentration. And to be able to do the more quantitative, if you want, analysis of the studies, we used an algorithm called Harmony for harmonized data. One issue, I skipped a few slides that show you that essentially there's a significant batch effect between specimens that are acquired from different clinical centers. And to be able to correct for this batch effect, we used Harmony to correct for this, and identified similar clusters here of DNA damage response, and somewhat more homogeneous data throughout the different specimens, even though they come from different centers. And what we saw, the strongest correlation that we have is between the drug level here with the cluster that essentially assesses response by reporting on DNA, the DNA damage response. So essentially here, even all the way into the clinical trial specimen, we see a very strong correlation between drug level in terms of the exposure, not the dosage, and drug response. So now, even though a lot of those specimens were sent to us and labeled as contrast enhancing versus non-enhancing, we had no way of knowing really where they came from into the tumor. And sometimes the drug levels can be very similar, so we're not sure how accurately contrast enhancing, non-enhancing labeling comes from the trials. So what we have been doing at our center is to bring back the stereotactic sampling that I've mentioned at the beginning, to validate our intraoperative analyses with those drug analyses. So essentially here, that was for the BKM 120 trial, where we take specimens in the contrast enhancing, but we labeled them on the imaging, so we have we know where they came from. And then we can perform the similar type of analysis here of drug distribution. And essentially here in this case, what we saw is, if we had done a standard drug analysis and taken the specimen, we would have thought, and grind the tissue, we would have thought we have a high drug level and should have significant response. But what we saw in this case is that most of the drug is found into the normal part of the tissue, and not so much into the tumor region here. So this is the type of information now that we're working to bring into the analysis of clinical trials, so that rather than failing on a trial and toss it aside and move on to the next drug, so that we can start better understanding why do we fail in those trials, and hopefully find ways to remedy to some of those limitations. So increasingly, what we want to do is to take advantage of the richness of those spectra. As I mentioned, we have information on thousands of molecules from those images, and we're interested in mapping metabolism into tissue and into the brain. And here is one case where this is in preparation for a clinical trial where the pathologist had mapped the levels of CD73, which is an extracellular enzyme that converts AMP to adenosine. And they wanted to see if we could detect adenosine into those tissues. So in red were the specimens that had high level of CD73. Those were all banked specimens, and we compared to the low levels. But in doing so, they had asked us to do to map adenosine. In doing so, we were able to map most of the purine metabolism altogether. So in red here, you can see all of the metabolites that we were able to acquire in one of those images, and in gray are the ones that we're working on to add to the analysis. And another way to visualize this is you can see here the specimens that had a high level of CD73. And I should say that people developing this trial would want to use those analyses as markers of response, but we can see the metabolism of ATP to ADP, MP, adenosine for each of those specimens. And here as a group, we can see that there's an increase in adenosine level by almost over a factor of 3 in the group that had high level compared to the low level. So we're doing increasingly those types of analyses now to assess response to drugs, but also one of our interests now is we've been working out methodologies to assess metabolism in response to neuronal activation. So in summary, I've shown you mass spectrometry imaging application to support clinical decision-making that we can use for the integration of spatially resolved pharmacokinetics and pharmacodynamics in animal models, but we can now do those analyses to study clinical trials. And the area that we're moving more into, and I'm very excited about, is to do spatially resolved metabolomics, both at the microscopic level into the tissue, but combine those stereotactic sampling and visualize detailed metabolism in the 3D volume of tumors. So this is extremely collaborative work, and I'm the one who's privileged to be able to talk to you about this this morning, but it's a large team. And I'd be happy to take any question.
Great, thank you so much, Nathalie. That was a really incredible talk. You know, there are so many questions that come up here. The first is, you know, you're starting this and you're innovating this, but can you speak a little bit to the cost effectiveness on a more global scale? You know, does it make sense to be doing mass spectrometry in the OR? And if so, how do you see us getting there to a point where it, you know, we can do this not just at Brigham and at Harvard, but, you know, all across the country and all across the world if it's going to make a difference clinically?
Yeah, so there's an increasing number of groups who are sharing that interest. I think the first more, if you want to call it, cost-effective way and the service that could probably benefit the most surgery is the one where we use that 5-minute molecular frozen section analysis, because in this case we'd be able to cater to multiple ORs simultaneously and really provide a new level of information. We're doing this also for breast cancer. In terms of the handheld, or, you know, being able to assess the tissue in real time, I think this is definitely something that's maturing. And as we're very focused on validation. So if you have a mass spectrometer and you walk by it with an ambient ionization, you'll get some signal. And for me, the big danger is to be able to validate what it is that we're visualizing or assessing. I'm very confident now that it provides very robust and reliable information. But the challenge will be to turn this into tools that are smaller and more affordable if you want. And one of the challenge, and it depends for the different types of surgeries, if you do a point analysis within the surgical cavity, if you're assessing not even a millimeter at a time, it depends on the type of surgery. It works well for brain tumor surgery when we peck at the tumor, but for regions that you need to cover a broad region, that might not work so well. So we're trying to not force one tool on everything, but to develop different tools to be able to cater to different needs.
Thank you. And then the second question I had was, in terms of screening for therapeutics, I know you're looking at your preclinical models. How well do you feel like the distribution of the pharmacodynamics preclinically is correlating with the results that we've seen in trials and in humans? And I think particularly I saw that sometimes you're using flank distribution models, and is that really correlating from a pharmacodynamic standpoint?
Well, so this is the study that I showed you here with AZD 1775. We're wrapping up to publish. That's the first one that we've done so extensively. If you want to go from the model into the trial and then back and forth with the models. And I have to say, I'm pretty surprised to see how much correlation there is. And at the end of the day, it seems to be a dose-dependent response. So, and what we know now is that, well, drugs, as you can see, distribute very heterogeneously. So even though you would be able to treat part of the tumor, parts of the tumor are treated at subtherapeutic level. And we know that for many of those targeted therapies, if you treat at subtherapeutic level, you often increase proliferation and invasion. So, I'm surprised for this one study. In any case, there is a strong correlation.
Great, thank you. Does anyone have any questions?
Hey, it's Ted Schwartz. I have a quick question, if I may. First of all, outstanding presentation. Thank you so much. Can you guys hear me okay?
Yes, thank you.
Okay, great. So just a quick other application. I don't know if you've thought about or worked with some of the pituitary surgeons that you have there to do mass spec looking for Cushing's. Maybe if there's a peak for ACTH, it might be really useful for some small hormone producing tumors to get real-time feedback of the tissue you're removing.
Yes, we've done that with Dr. Laws. We've done that in banked specimens, so we can very nicely detect hormone levels. We can identify them, and so it works really well. We did this for secreting microadenoma, and in this case, we use the MALDI version, like we use a tissue section to be able to do those analyses. We published this in PNAS, and it's probably one of my favorite grants that I wrote. And then the NIH reviewers said that nobody cared about pituitary tumors because people don't die of their diseases. So there's a kind of, it's so upsetting, but that's definitely something that we want to continue and pursue. Yeah.
Yeah, well, if you're ever looking for some collaborators at other institutions for intraoperative sampling, let us know. But that's fantastic work.
Oh, that would be great. Yes, yep. Thank you. Perfect. And I have to say, so from the time that we published that study, we were very proud. We had been able to bring the analysis down to 30 minutes. And the 5 minutes now is something of this year. So, yeah. And I have to say also, I think I had this one more slide that, if I have a minute, is that we are building a new laboratory, which should now be ready in October. We were stuck by the pandemic, but essentially this is pretty much next door to the frozen section room. And here is where we can have an instrument to do the analysis of specifically the pituitary tumors at the time of surgery.
Fantastic, thank you.
You're welcome.
It's terrific, thank you so much. I think it's been a really wonderful experience to have you come out here. I hope that one day we can host you in person, but thank you for
I would love to.
Being so flexible. Okay.
Well, thank you for inviting me.
All right, thank you everyone. Have a good morning.
You as well.